Good evening, everyone, and welcome to the first Leading Voices in Public Health for the 2017-2018 academic year. This is the 11th year that we've been doing Leading Voices, and we've had over 50 different events featuring over 70 different speakers. And the idea behind the series is to bring in folks from the outside who can not only inform us, but also challenge us to think about new ways that we can go about improving our health in this region, and from this region, then the state, and from the state, then the nation. And we're really fortunate tonight to have three experts with us to talk about an issue that sort of reflects a pattern that we're seeing in public health around the world. And that pattern is a disease that has been under control, stops being under control, and starts resurging. So we saw it with malaria, we saw it with tuberculosis, we see it in this country with measles and other vaccine-preventable diseases, and tonight we're going to hear about the resurgence of black lung in Appalachian coal miners, obviously an issue of incredible importance for this region. We're joined by three speakers this evening. David Blackley, many of you know, is one of our own alums, graduated with the DRPH in 2013, went on to the Epidemic Intelligence Service, and is now at the National Institute of Occupational Safety and Health in West Virginia. He'll be joined by Dr. Scott Laney, who is also a former EIS officer and also is at NIOSH in West Virginia. Scott has a PhD in molecular epidemiology and has been working on these issues for some time. And they're both going to be joined by Dr. Brandon Crum, who is a radiologist in Pikesville, Kentucky, and I am told a former coal miner himself. So we've really got an incredible group of folks here for us this evening. So please join me in welcoming Dr. Blackley, Dr. Crum, and Dr. Laney. I would recommend this mic.
Okay, thanks. Well, thank you. Since he graduated from here, David and I have been working on a variety of things, but principally on Ebola in West Africa and black lung disease here in Appalachia. And in fact, we're currently conducting an outbreak investigation of black lung less than 60 miles north of here. So we appreciate the invitation to come and speak on this topic. And David asked me if I would talk a little bit about the importance of black lung and specifically why you should care about it. Coal production was probably the largest influence in moving us out of the pioneer days and into modern day life as we know it. And so that's probably the most compelling reason to care about coal. Nearly all of the coal that's mined in the United States is used to make electricity. And in the Western world, access to affordable energy has become a basic human right, and we treat it like we do potable water and public education. This is the distribution of the fuel sources that we use for power consumption in the United States. About a third for coal, a third for natural gas, and a third for nuclear and renewables. And natural gas has really come on strong and has recently displaced coal as the primary fuel source in the United States. Now, Tennessee doesn't produce much coal. Nearly all of the energy production in the state is from nuclear and hydropower. But that said, Tennessee uses a tremendous amount of coal. And the most recent numbers show that about half of the electricity generated in Tennessee is actually derived from coal power plants. And since it isn't produced here, nearly all of that is brought in by rail and by barge. And overall, Tennessee uses about 20 times as much coal as it produces. Now, there are 10 coal mines in the Cumberland Plateau that nearly all of that coal mined here is exported out of state. Oh, great. Trigger finger. One interesting fact is that you currently have some of the cheapest electricity in the entire world. Now, you rank about 19th or 20th in U.S. per capita consumption, and so energy is very inexpensive, and you use a tremendous amount of it. This map's a bit dated, but shows the U.S. coal mining regions in the United States. This gray region is the bituminous coal in central Appalachia and the Illinois Basin. And then out west and in the south, we have subbituminous coal and lignite coal, which is a lesser desired, lower rank carbon coal. The bituminous coal fields are through these counties in Tennessee, and there's also a sizable untapped lignite reserve in western Tennessee that could potentially be explored in the future. So we've touched on some of the historical reasons and the positive economic impacts, and another reason that coal is important to Tennessee is actually the negative economic impacts and the environmental impacts. As I mentioned, millions of tons of coal are transported into the state, and issues can occur that have environmental consequences as a result. In this instance, a train derailment dumped over 1,000 tons of coal next to a river in a national park in Scott County. Another environmental consequence of coal that I'm sure that everyone in this audience is familiar with is the Kingston coal ash disaster that led to an agreement to make that a Superfund site. And ultimately, the cleanup took over 6 years and cost $1.2 billion, according to the EPA's numbers. So even though coal mining does not pose the same sorts of direct environmental impacts that we see in West Virginia, in Kentucky, it does continue to play an important role in Tennessee with regards to these other types of environmental impacts, to say nothing of the emissions from coal-fired power plants. So these are a few reasons to motivate the importance of coal, but the primary focus of our talk today is the toll that coal mining takes on the health of the men and women who mine it. And these gentlemen are going to talk to you about that.
So Scott has briefly run through the economic and environmental reasons why we should care about coal in the United States, and especially in this region. He and I both work for the National Institute for Occupational Safety and Health, which is a part of the Centers for Disease Control, and our mandate is worker health. And so when it comes to coal, what we're most interested in is miner health. And from a regional point of view, why we argue that people, even in the Tri-Cities, and I'll admit, when I was here, I didn't think much about coal or the impact of coal, but as the crow flies, we are about 50 miles due south of what we believe to be the epicenter of this resurgence of severe disease, and that's well within the catchment area of many of the hospitals and health systems that serve this city and this region. I'll take just a half step back and talk a little bit about some of the coal or mining specific occupational safety and health historical highlights in the U.S. Coal miners were unionized relatively early in the 1890s. Within about 20 years, the Federal Bureau of Mines was established. Their primary mandate was research and development to prevent major disasters, mine catastrophes, things like that. Over the next couple decades, a law was passed that for the first time allowed federal inspectors to enter a mine to do inspections. There weren't directed occupational and health standards at the time, but it was the first time that federal inspectors were allowed to enter the mine. As Scott mentioned, during the war years, coal built America. It's what built up the East. It's what allowed our expansion westward. And so along with that economic boom came increased health and environmental concerns. And then it wasn't until about the 1960s that we started to see action, legislative action, that formed the basic framework of what we continue to work under today in 2017 in terms of occupational health and safety standards. And unfortunately, as is often the case with mining, or with any issue, within mining, it took worker activism and a large-scale catastrophe to motivate change and to finally get some regulations on the book that had teeth. There on the right is a picture from the Farmington mine disaster in 1968. 78 miners killed at the Consol No. 9 mine just outside of Fairmont, West Virginia, which is about 25 minutes south of where we work. And then in 1969, in Raleigh County, West Virginia, which is in the southern coal fields, the walkout from coal miners because of dusty work conditions that ultimately resulted in a large-scale strike of upwards of 40,000 coal miners. So they essentially shut down eastern coal mine production, which at the time shut down the country. And all of that culminated in 1969 with President Richard Nixon signing the Coal Mine Health and Safety Act, which at the time, like I said, was the first regulation with occupational health and safety related teeth that established the first permissible exposure limit for respirable coal mine dust at 2 milligrams per meter cubed. So 2 milligrams of respirable coal dust per meter cubed of air. And it empowered NIOSH, which is Scott and I work for, to conduct health surveillance of working coal miners. And that surveillance is conducted and has been conducted by NIOSH since 1970 through what we call the Co-Workers Health Surveillance Program. Tonight I'll probably just refer to it as the surveillance program. It's mandatory that the program be offered. It's voluntary that miners participate. They participate and have chest x-rays taken during their working years and then are confidentially informed of the results of those x-rays. The main focus and the main goal of surveillance and of our surveillance program is to detect coal workers' pneumoconiosis, which is, to be clear, that's black lung, and we'll refer back and forth to it as either black lung or coal workers' pneumoconiosis, to detect it early so that action can be taken to prevent the advancement of disease. And to provide that information to miners in a confidential way so that then they can make the choice whether or not to exercise their right to move to a less dusty part of the mine. The focus of our talk tonight will be more on the bottom bullets, and that's some findings from the basic science that we're able to conduct because of this surveillance program, and then some findings as they relate to surveillance of coal workers' pneumoconiosis among U.S. coal miners. And dust is the only cause of black lung disease. Smoking doesn't cause it. Environmental exposures outside of the mines don't cause it. Coal workers' pneumoconiosis is caused by workers being exposed to too much coal mine dust. It depends on the amount and the composition of the dust, but not much else. Here are these are sections, frozen, freeze-dried sections of lungs showing, in terms of anatomy, what coal workers' pneumoconiosis looks like in a lung. And so there on the left you have a healthy lung. In the middle you have what we call simple CWP, which is where you have small, separated macules of coal that cause a progressive stiffening of the lungs as they continue to deposit in the tissue. And then as the inflammatory pathways continue and as the dust continues to deposit, you can have a coalescence of all of those separate macules and an advancement from what we call simple CWP to what you see on the right, which is sometimes called progressive massive fibrosis. It's often called complicated black lung too. And that's where as you can see here, all of the separate macules come together to form these large lesions that replace the lung tissue. There are a variety of ways, including things like CT scans, to do imaging studies for coal workers' pneumoconiosis. Tonight we're going to focus specifically on just plain frontal chest x-rays, because that's what we use for surveillance purposes among U.S. coal miners. And when an x-ray is taken of a coal miner, then there is an expert physician, which we call a B-reader, who is a physician who has taken specialized training and has been certified by NIOSH to read x-rays for occupational lung diseases. In fact, Dr. Crum is an NIOSH B-reader. They use international standards. In the United States, we use what are called the International Labor Office standards, and then they fill out this form that you see here on the right and document the findings from the x-rays in terms of the perfusion, so the spread of the background scarring on the x-ray, the presence or absence of the large coalesced opacities, and then other characteristics seen on the x-ray. And so in terms of classifying radiographs, when you use the International Labor Office system, You take a standard film, which shows either normal conditions, or a normal lung, or the progression of the disease. So you stick the standard film up, and you take the film from the minor, and you compare the two, and you see what the best match is, and that's how you do the classification for disease. And so here you can see a normal radiograph. Then you get into the range of what we call simple CWP, and you can see as you progress through Category 1 to Category 2 to Category 3, simple CWP, you see an increasing profusion of these small background opacities. And then as you get into what we call progressive massive fibrosis, you get a coalescence of those opacities. You continue to have background scarring as well, but through Category A, B, and C, progressive massive fibrosis, it continues to take up more and more space in the lung. Category C is defined as the largest, the longest diameter of a lesion taking up more space than what would be equivalent to the right upper lung zone. So very severe disease, and it takes huge overexposures to develop disease this bad. So, like I said, Coworkers Health Surveillance Program is primarily a service program to provide confidential health information to minors. But we don't want to waste that information. We're also able to use it for basic science and surveillance. The x-rays from that system have been an excellent resource and continue to be an excellent resource. In fact, we have nearly 1 million of them in our basement at NIOSH from before the time that we switched over to digital. But we also look for other sources of information because as a voluntary surveillance system, we don't capture all working minors, we don't capture former minors, and as a chronic progressive disease, a lot of the worst cases are seen in recently retired minors or some older minors, and so we look at workers' compensation programs from state and federal systems. We look at accident and injury reporting systems from federal regulatory agencies. We can look at mortality and transplant data, which are a very clear and hard endpoint. And then, as we've started doing more in recent years, we can go directly to clinics who see these minors and see what their experience is and see how much overlap or non-overlap there is between what we see in our surveillance program and what they're seeing day to day in the clinic. And I'm not going to go through this list here. This is basically starting at the end. So what do we know? What we know now is that in 2017, the prevalence and the severity of coal workers' pneumoconiosis among U.S. coal miners, and especially among coal miners in Appalachia, is as bad as we've ever seen. And put more succinctly by some friends of ours at the Appalachian Citizens Law Center in eastern Kentucky, they said late last year, black lung among Appalachian coal miners is quite literally worse than ever before, which is a hard thing to process in 2017. As I mentioned, it was around 1969 or 1970 that federal regulations for dust control kicked in. It became, a penalizable offense to have for operators to have dust levels that are too high in the mines. And as you'd expect, from the 1970s through the late 1990s and around the year 2000, there was a steady decline in the prevalence of coal workers' pneumoconiosis among U.S. coal miners. And then around the year 2000, especially among the longer tenured miners, we started to see a reversal of that trend. And when you just focus on miners in Kentucky, Virginia, and West Virginia, which is what we call Central Appalachia, that resurgence seemed to be even more pronounced. And based on our estimate among working miners, longer tenured working miners, somewhere between 10 and 15% of them who were still working show evidence of coal workers' pneumoconiosis. And when you shift to just progressive massive fibrosis, which showed earlier is the most severe form of the disease, gross overexposures lead to PMF. around 2012 when we reported on this, or 2014 when we reported on data through 2012, we found that the levels of progressive massive fibrosis were about on par with what we saw when we first started recording numbers for this disease in 1970. So there had been a total U-turn. And then last year we said, well, let's revisit that data and see if we can update it. And we unfortunately had to change the scale, as you can see. So the curve is the same, but through 2015, 2016, now we can say among longer tenured working coal miners in Appalachia, about 5% of them have evidence of severe, complicated progressive massive fibrosis. And as a reminder, this is what we're talking about when we say PMF. These are not the more subtle, smaller lesions. This is severe, debilitating disease that forces someone to quit working and that ruins lives for the miner and the family. We haven't just seen an upswing in the prevalence of severe disease. We've seen troubling increases in the actual severity of the disease itself. This was a report that NIOSH published within the last 6 or 9 months, I believe, that found that for miners, for working miners who participated in our system, for the ones that we had more than one X-ray in recent years, 1 in 6 progressed from a normal radiograph to large opacity, progressive massive fibrosis in less than 10 years. And that's a phenomenon that is incredibly troubling, and it's something that when you speak with people who've been involved with this issue for many years, it's something that didn't used to happen with any regularity. And one of the reasons that's been proposed for why we may be seeing more disease and more severe disease is increasing silica exposures among the miners who remove this coal from the mountains. And that could be in terms of smaller and thinner coal seams being mined with bigger and more powerful equipment. So you've got the roof and the floor, and there's more rock, more silica rock being generated. And that could explain this phenomenon, but there hasn't been great data, great peer-reviewed published data on that historically, and it's something that we're growing increasingly interested in, and there has been some work on. There was a project that NIOSH undertook several years ago that we're in the process of updating now that focused on the actual shape and size of the lesions that we can see on the radiographs in our system. And so B-readers don't just categorize the profusion of small opacities and the presence or absence of large opacities. They also categorize the shape and size of the shadows that they see on X-rays to characterize the lesions themselves. And as you can see here, these larger round lesions that form the background scarring on radiographs, they're called R-type opacities, and they have been it's well established that they've been correlated with silicosis pathology in separate studies. Our program doesn't do a lot of pathology, but there have been separate studies where they've looked at X-rays, and then they've actually been able to look at the tissue from those miners, and miners with R-type opacities on their X-rays have been shown to have silicosis pathology when you actually look at the tissue and the lesions themselves. And here's an example of a radiograph with a background profusion of these R-type opacities in a West Virginia roof bolter. And a roof bolter is a person who operates equipment that pins the roof rock in a mine to straight of rock above it to support the roof system. I believe Brandon will talk about roof bolters a little bit later. So we said across time, has there been an increasing proportion of X-rays in our system that show evidence of R-type opacities, and is that a regional phenomenon? And so what NIOSH ended up doing was separating the U.S. into all of the U.S. coal mining areas and then just central Appalachia. We split it into two. Across time, in the rest of the United States, there had been essentially no change in the prevalence proportion of R-type opacities on X-rays for coal miners from the 80s to the 90s to 2000, and that's shown in the gray bars here on this screen. But within Central Appalachia, from the 1980s through the first decade of the 2000s, there's been a 7-fold increase in the proportion of R-type opacities among these miners. And in fact, this has become a priority for us again to update, and we've run some preliminary data on this, and it appears that for the next decade of the 2000s, so basically 2010 to now, this trend appears to be continuing. And that's something that we're going to prioritize moving forward with our research. When you think black lung, you think of the classic picture of a miner coming out of the underground mine, face covered in dust, and going home and coughing, and that's kind of the historical image of black lung. But it also occurs among surface coal miners, including surface coal miners who've never worked a day underground in their life. And NIOSH has reported on this in a number of articles in recent years, and Kara Halden, a colleague of ours, has also done some detailed case series investigations focusing not just on the radiographic findings, but on the self-reported work practices of miners. And this miner 8 here, who was in a case series that she did a couple years ago, took meticulous photographs at work from his time in the early 1980s all the way through the last photographs down there from about 2012. And if you didn't see the timestamps on these, it would look like they were all taken from the same time. And it's clear that in his case, dust exposures were not reduced over time. And this guy was a driller. And so these are pure rock dust clouds, pure silica. And silica is many, many-fold more toxic to lung tissue than coal dust is. And so in addition to taking meticulous photographs on the job site through his career, he actually participated in the Coal Workers Health Surveillance Program too, and he came and he got x-rays through his career. His x-ray at age 46 showed no evidence of disease. He wasn't impaired, he continued working. At age about 56, he began to have progressive shortness of breath. The next year, he went in for his NIOSH x-ray, which miners are encouraged to receive about every 5 years as they continue to work. And he showed bilateral upper zone, what was determined to be PMF stage A, and his doctor diagnosed it as silicosis, and he also had large airways disease, COPD, and his physician recommended that he stop working, even though he didn't plan to do so for at least 5 more years, and he did, and he retired early. And this is a miner who never smoked and never worked a day underground in his life, and severe PMF, and the end of a career early. So up until now, I've only spoken about data that's generated by our program, by the surveillance program. But because participation in our program is voluntary, and because, generally speaking, our mandate is not former coal miners, we only see a portion of the complicated black lung that exists in the United States. And so this is a really crude pictogram of that I made in my office. But basically, if each dot is a case of PMF, we're only seeing a sliver of it. And so we need to come up with more and creative ways of figuring out what the true burden of disease is that's caused by coal mining because of the implications that has, including prevention, regulations, and then more importantly, workers' compensation as a remedy for miners who have developed disease as a result of their careers in the coal mines. And so from this list I showed earlier, the top 2 relate to the x-rays that we get in our surveillance program, but the rest relate to sources of information that are totally independent of NIOSH. And so we've also tried to partner with other people to enhance what we can do to understand what the true burden of disease is that's caused by coal mining in the United States. And there was an excellent case series that was published just a few years ago looking at actual pathology, which is one of the limitations of our program, is that we don't have much of that. And here you can see this is an explanted lung. So this is a miner that got so sick that he required a double lung transplant. And there on the left, you can see progressive massive fibrosis. The lesion basically replaces the whole upper portion of the lung. And then there on the right, There's some slices from that actual lung. On the left, it's a slice from the PMF lesion. On the right, it's a slice from some of the simple CWP lower in the lung. And on low magnification microscope, both show clear evidence of silicotic lesions. And so this is good evidence that in contemporary miners with severe and with rapidly progressive disease, there is more and increasing evidence of serious silica and silicate and other rock exposures in addition to the coal that they're breathing in as they mine. It's not the focus of tonight's talk, but what's called the Federal Black Lung Program is the workers' compensation program for U.S. coal miners. And so that's a separate, independent source of information that suggests what the true burden of disease may be in the United States that's separate from our surveillance of active coal miners. And unfortunately, in the last decade, we've seen a steady increase in both new claims and refiled claims, and these are separate individuals for federal black lung benefits. And our understanding is those trends are similar when you look at state claims from places like Kentucky, Virginia, and West Virginia. And because workers' compensation data is such a rich source of information that we at NIOSH haven't historically had good access to, we've formed good partnerships with colleagues at the University of Illinois and with folks at the Department of Labor to try to take a deeper dive in what we're calling it the linkage study, basically between surveillance data and workers' compensation data. And we're looking at things like overlap, gaps, and also longitudinal findings from a linkage of separate surveillance data, separate workers' compensation data, and you can use unique identifiers to link the two and get a better understanding of the burden of disease. And this is an exciting area of work that we've focused on a lot in the last couple of years, and we're just starting to get it off the ground. And this is my one plug for the night. While we're on the topic of workers' compensation, if you say, I don't know anything about black lung, but maybe I'm interested in learning a little bit more, if you read one article about black lung, and especially about black lung workers' compensation, I would recommend this. It's a series of 3 articles called Breathless and Burdened, written by Chris Hamby, who at the time was with the Center for Public Integrity. And if this article, it takes about a half a day to read because it's so long, but if you want a Pulitzer Prize for investigative journalism a couple years ago, it's an incredible article, and if it doesn't leave you crying at the end of it, then I argue that something's wrong with you. I'll only spend a few seconds on this slide. I just want to emphasize this is another independent source of data that we're able to look at, and this is mortality data. So this is separate data that comes from death certificates. And what we're looking at here is what's called years of potential life loss. So it's basically the number of years that you don't live below age 65. And so if you die at age 62, you've had 3 or 4 years of potential life lost. And so it's a useful and some kind of crude way of looking at premature mortality. And if you look at the dashed line there, which is mean years of potential life lost, what that says over there on the right side is that in recent years, for each coal miner who has coal workers pneumoconiosis listed as either primary or contributing cause of death on their death certificate, somewhere between 8 and those miners on average experience somewhere between 8 and 10 years of potential life lost below age 65. I believe this is one of the last slides that I'll show from our data, and then Brandon will get up and talk a little bit more about the clinical experience. But lung transplants are, aside from death, they're about the hardest endpoint that you can measure in terms of the burden of severe black lung disease in the United States. And this is something, lung transplants for severe black lung weren't performed 10 or 12 or 14 years ago. It's only been in the last decade that we've started to see these procedures occur. And we're able to mine national transplant registry data, which are kind of messy and aren't built to do this sort of work, but it's a growing area of research for us, because if we can figure out how many patients in that system who have lung transplants have it because of coal workers pneumoconiosis, it's incredibly useful for us to help understand the burden of the most severe form of this disease. And as the data show here, it's only getting more frequent in recent years. So since the year 2000, and especially since about 2010, as there's been more and more scientific reporting on this resurgence of disease, it's generated more and more lay audience interest in the topic, which we think is a good thing, because this is an issue that we shouldn't sweep under the rug. It's been reported on widely in national news outlets, in regional news outlets, and not surprisingly, the focus shifted to, well, if we're seeing more disease, should we revisit the regulations governing black lung in the United States? So basically the dust regulations for coal mines. And those are something that have been stalled for many years. In fact, in 1995, NIOSH issued a formal document recommending that the allowable level of coal mine dust in the mines be lowered from 2 milligrams to 1 milligram. And through the years, for a variety of reasons, no action was taken on that recommendation. But Senator Rockefeller, who was the senior senator from West Virginia, picked this up as kind of one of his last causes several years ago before he retired. Here he is, I believe, at a meeting in Bluefield, West Virginia, in the southern coal fields. There in the bottom is Dr. Don Rasmussen, who was the patron saint of coal miners in southern Appalachia. He saw hundreds of thousands of coal miner patients through the years and died a couple years ago in his late 80s, I believe. And he'd seen patients right up until the end. Anita Wolf is there on the left. She manages our surveillance program. And then Terry Fike is the woman seated to the immediate right of Senator Rockefeller. Her husband, Chester Fike, who actually was a neighbor of Scott and Tammy Laney outside of Brewston Mills, West Virginia, was a 35-year coal miner in northern West Virginia and developed very severe black lung disease later in his career. And in fact, this is a picture of Chester here, and MSHA used him with his permission as kind of the poster child for this issue, for the resurgence of black lung, and emphasizing not only the human but also the economic burden of this disease. And this is his lung. This is his explant. This is Chester's explant. In 2012, he received a double lung transplant after 35 years of coal mining. And I believe after about 4 months, he passed away. And so in 2014, MSHA updated their regulations. It caught us a little by surprise. They lowered the permissible exposure limit for dust from 2 milligrams to 1.5 milligrams, so it wasn't down to the 1 milligrams that NIOSH had been recommending since 1995, but it's a step in the right direction. They expanded surveillance that we offer to include spirometry, which is lung function testing, which can detect things like COPD, which can also be caused by coal mine dust. It extended surveillance to surface miners, and it included what we call a respiratory health symptom assessment, which we administer in our mobile unit that goes around the country providing x-rays to coal miners. And so we see these regulations as a step in the right direction. And I'll stop there presenting data from our system and other parallel systems, and invite Brandon to come up to talk a little bit about our experience in Pikeville, Kentucky over the last couple years, and what we've seen at his clinic, and how we can use that to learn about black lung in Appalachia and what we can do to improve things.
Thanks, David. Thank you guys for having me. So a little bit of background. I'm a diagnostic radiologist in Kentucky in Pikeville. And before that, I did 2 years internal medicine and transferred into radiology and did my radiology training at Kettering up in Ohio, and came back and worked in the hospital, a couple different hospitals for a number of years, and then actually joined a large multi-specialty group, or a pretty good sized one in eastern Kentucky, that put me into a private practice and allowed me to kind of spend some time with things that I like to do. So one of the things at our clinic, we offer x-ray and imaging and things like that, and we receive x-rays from miners from a lot of different sources. We receive them from our primary care doctors, our mid-levels. There's attorneys that send them in. We do occupational chest x-rays, pre-employment physicals for coal companies and things like that. We're a NIOSH certified location. We do x-rays for NIOSH. But I started looking at them, and I'd always seen quite a bit of PMF, but what concerned me in the last 2 to 3 years was the amount of complicated black lung that I was seeing, especially in younger miners. And I've got some examples of that I want to show you today. So I was seeing a lot of these cases, and I kind of went up to PipeStem, which is a black lung conference in West Virginia, and I talked to Dave, and I talked to Scott at that time, and I asked them, and I showed them told them what I was seeing, what I thought I was seeing, and invited them down, and they came down to the clinic there in Kentucky and looked at the cases and agreed there was concern, and reevaluated it 2 or 3 times just to make sure, and we went from there, and we actually co-authored a paper that released in December of 16 by the case definition. We had International Labor Office interpretations of large opacities, category A, B, or C's, in coal miners who received an x-ray at the clinic there in Pikeville, our clinic, from January 7th, 2015 to August 17, 2016. So, roughly about a year and a half or something like that. We had a completed x-ray reading sheet, and then we had a completed occupational history form. And at our clinic, we have multiple people that do different studies. We have ultrasound techs, MRIs, and x-ray, but I only have one x-ray tech that does my black lung stuff because she's really, really good at it, and she's really consistent with it. And what I've tried to show her is and she's really picked up it quick, is when she has an x-ray on a miner that's, and I'll just say bad, but that means a perfusion in which she sees a lot of nodules, or she sees those large masses, which I'm going to show you in a minute, then she'll actually come and get me, and I'll go in there and I'll talk to that man. I'll bring him in, and I'll show him his x-ray, and a lot of them have never seen their chest x-ray before, which is really concerning to them when you show it to them. But I've got 2 or 3 sheets, and I take an extremely detailed work history on those miners, and it includes what they did, how many different things they did on the surface, on the underground, where they worked at, the seams they were in, how much rock they took, what type of rock, what type of coal, geographical location. So it's a really extensive work history on them, and I've did that probably for about 800 to 900 miners. So we're closing in on 1,000 miners that we have that degree of detailed work history, and then I get to compare it to their x-rays and correlate those two and see those findings, how they add up with everything on them. Additional information that I take, I try to get old x-rays if I can get them. CT scans are great for me because you can think you see stuff on x-ray, which is a little bit, and if we have doctors or medical students, you'll order a CT to confirm it and take a closer look at it. I try to get all the pathology notes that I can if they've had any biopsies, bronchoscopies, or path if they've had a lung transplant. The detailed occupational histories already went over that, and I try to get a status on them if they've had state or their federal black lung claims, if they've been approved, denied, and things like that also. So here's an example of a normal x-ray, and you can see kind of the dark areas. That's the lung fields, and it's dark because it's good because it's filled with air, and there's nothing in there that shouldn't be in there. So this is a classic normal x-ray. And you'll contrast that to these x-ray, or this x-ray here, and you can see these large kind of white conglomerate masses within the upper lobes and in the middle lobes or the middle lung. And this is on a miner. All these x-rays I'll show you and CTs are on men that was at my clinic, and they're all younger than I am. So this is a category B, in which you have these huge masses in the lungs, upper lobes and middle lobes, consistent with complicated black lung disease. And when I say complicated, that's the same thing as PMF, or progressive massive fibrosis. And one of the most concerning things on these guys, and any miner for that matter, is even though they'll have an x-ray like this, I'll show it to them, I'll tell them what I see, even if they come out of the mines that day and never go back in, there's a significant chance that it'll continue to progress. So even though they're taken out of the dust, there's still an inflammatory process in the body that triggers, in some of our miners, especially our central Appalachian miners, which continues to worsen these x-rays even though they're taken out of the dust. So that's a big concern also, and one of the things that we want to do to try to help to find it early and educate medical providers and miners also. Here's another case in which you have just multiple, all that white area in the middle lobes and upper lobe is just significant, huge fibrotic masses in the lungs. And once you have this degree of fibrosis within the lungs, the upper and middle lobes, there's no lung function in that area. The lung's completely fibrotic and destroyed, and there's no treatment for this at all. We don't know of anything that can treat it or make it better, and you still run the rate or possibility of continued progression even though they're taken out. So here's an example, and you can see this is just massive, progressive massive fibrosis, both sides. And the fibrosis is to the point where it actually will start to elevate or contract and lift up the hyla. There's that much fibrotic process in the lungs going on. This also, you can see significant emphysema in this individual, which is also one of the possibilities that's also caused by dust and not just smoking. This individual was 39. So here's some examples of CT, and you can see on your left the white arrows with the long one. That's you're pointing out the little white dots. That's the simple black lung. That's just the small nodules. And once these nodules either come together or they form a mass that's 10 millimeters or a centimeter in size or greater, then that kicks it over into the complicated state. And you can see your CT scan on the right, which is in a coronal plane. You can see all those white areas within the upper and middle lung zones are consistent with PMF or progressive massive fibrosis and complicated disease. So the young man there sitting beside me is named Mackie Branham, and Mackie was one of the men or miners that was featured in a lot of the articles and things when we released. After we released, there were some stories, and Mackie worked for less than 20 years in the mines. And when Mackie came to the clinic and got his X-ray, the X-ray unit between my offices and to the X-ray is about 60 feet. So, and Mackie couldn't make it 60 feet before we had to get a chair and let him sit down. So, and he was, at that time, when we first diagnosed him, he was 36 years old. So Mackie was treated for about 6 to 9 months for pneumonia. And that's one of the problems that we're seeing is that our medical providers, especially in Central Appalachia, aren't looking for this degree of severity in black lung in this young of a population. So a lot of the time they're treated for pneumonia or some kind of fungal infection or some kind of atypical pneumonia when actually it's complicated black lung in these individuals. So he went about 6 to 9 months when he just kept getting treated for pneumonia, and when he wasn't sick he went back and worked. And Mackie was a miner man, and that's the person at the face in which he actually sits there and grinds the coal, and then it's extracted from the face. So he was a significant risk for dust burden in his job. So that's one of the things that when we're going around to all the medical schools is to educate the medical providers to increase awareness for the disease in its early stages. And this is Mackie here, and this is actually at his house. And, you know, when you think about black lung disease and you get a picture of somebody in your head, it's usually a 65 or 75-year-old person with kind of a scraggly beard and dusty face. But this, unfortunately, is what we're seeing in significant numbers in eastern Kentucky, especially, is people younger than I am with severe disease. And Mackie's on transplant list now, and Mackie's on oxygen now. And he came to the clinic about 3 weeks ago when the NIOSH van was there, and we re-X-rayed him, and his chest X-ray had progressively worsened in about a 6 months duration. So unfortunately, even if Mackie gets lungs for his transplant, the average survival for a miner with a transplant is 3.7 years or less. So he's just biding time even if he does get lungs. This is his family. He's got a wife and 4 boys. His oldest one's in high school and just started driving. I was talking to him a little bit, but and this is not unusual or atypical for what we're seeing in eastern Kentucky. I wish it was, but it wasn't. The worst chest X-ray that I've ever seen came into the clinic 3 weeks ago when NIOSH was there, and almost his entire lung fields on both sides is completely opacified from large opacities and areas of mass. You could barely see any remaining lung within both sides, and he's 40 years old. He just quit about 3 months ago. So that was the title of our article that we released in December. At that time, we had about 60 cases of complicated black lung or PMF during that time frame. We've had many more cases since then. I got a little bit of an update. About 75% of those were either roof bolters or what we call pinner man, is what they'll call them in the industry, or continuous miner operators. And if you'll see on your left, this is a dual-headed pinner or a dual-headed bolt machine, and they'll actually take those long pieces of metal or bolts and they drill them up into the roof of the mine, and that helps to secure the roof top to prevent it from falling on them. But a lot of it you'll see, instead of being black like coal dust you would expect, you can see their machine is completely white, and so are they. So there's a lot of silica exposure with this type of job. And on your right is a continuous miner down on the bottom. He's cutting coal. You can see the dust. This is what Mackey ran, and you can see you're not only grinding the coal seam, but a lot of the time they're grinding top and bottom both. And definitely silica is a significant component, but there's other factors which contribute significantly to the disease too. And after taking that much histories, we've seen that kind of repeating and repeating. So since then, in October of 16, we had about 60 at that time. There's now, and this was actually done last month before our other talks, but I'm up to about 135 cases now just in Pikeville, just at my clinic. That was the people that had them done there, not counting from where I read from all the other states. I read from multiple states, and this is almost epicentered in Central Appalachia. I'll read the Western Kentucky coal fields. I read the fields out in Montana, Wyoming, and Utah. And I've probably seen 2 to 3 cases of complicated black lung in the last 2 years, compared to just over 130 within the last 2 years there. So even though it's epicentered in Central Appalachia, I think the potential when we change, or they change their mining practices, when the easily accessible seams are gone and you have to get the less desirable seams to be mined, it's not only going to be in Central Appalachia, it'll eventually progress to the rest of the country and probably worldwide in a lot of industrialized nations. So we're about 135, and those are all cases of severe complicated black lung. And there's the average survival post-transplants, about 3.7 years. So what can we do to help? Well, we lecture a lot. We've lectured at multiple medical schools, and I really appreciate you guys having us here today, and I appreciate these guys, which are the best of the best in epidemiology, and they help me quite a bit, and I really appreciate them. We can obviously try to educate our miners and try to educate our medical providers and get people out to get screened so we can pick this disease up early. And the earlier we can pick it up, the better we have a chance of curbing it. We did a new Faces of Black Lung video, which we filmed there at the office a couple weeks ago, which will be released here with NIOSH and CDC in the next few weeks. And we have so many cases at our clinic that we're sending cases to Arkansas, and a lot of them will be in the new ILO standards for the world, which will actually be viewed here in the next, hopefully be completed in the next few months.
So we're about finished here, and I'll mostly skip this slide and just say what we intend to do is to continue to administer our national surveillance program, continue to partner with agencies that manage workers' compensation to take a deeper look in their data, and continue to work with clinics like Brandon's and others within Central Appalachia to better understand the burden of this disease. And this is either the last or second to last slide, and what I wanted to use it for was to close with a cautionary tale. And this is from Australia, where coal mining is a big industry too. They have a national surveillance program that for many, many years has taken x-rays of coal miners. They decided in the mid to late 1980s that there was no more black lung disease among Australian coal miners. In reality, there was. They had continued to take x-rays as part of their surveillance program, but no one interpreted those x-rays. They stuck them in a storage container, and no one looked at them. And so the lesson from that is that you can eradicate a disease by stopping looking for it. That's one way. And then to loop back around to our data, meant that a little bit as a joke, but also as a caution for us in the United States, and I think we've done an okay job of sticking with this. Basically, in the late 1990s, around the year 2000, we could have said, oh, black lung is eradicated among U.S. coal miners. You can see on both of these graphs, the levels get very low for all black lung and then for complicated black lung too, and we could have said the same thing, and I'm glad we didn't, because now we're faced with this problem that's going to require a lot of time and a lot of resources and a lot of commitment. And so we're finished there. We're happy to take some questions from the audience or afterwards, and maybe I'll turn it back over to you for a second, Randy. Here you go.
Well, you can keep it. What, if you don't mind, keep the questions from the audience. So the first question I've got is protective, preventative, ventilators. I didn't see any of that in the miners that you saw.
Sure. So respirators or personal protective equipment. There's a well-established, what it's called, hierarchy of controls for controlling exposures to things like dust in a mine environment or in any environment. And these are, this is a hierarchy that has been proven scientifically and in practice through the years. And at the top of that hierarchy are things like engineering controls, so water sprays, ventilation, curtains, and then also administrative controls, so moving people to places where there's less dust. At the bottom of that hierarchy is personal protective equipment, so things like respirators. And in practice, respirators should only be seen as a last-ditch solution when the other parts of the hierarchy of controls have failed. And in law, in fact, in the MSHA regulations that govern the control and the control of dust in American coal mines from the regulatory point of view, it's written into their law that respirators shall not be used as the primary means of protection, and should only be used as a last resort in emergency settings. And that's for a variety of reasons, including just the sheer difficulty that exists in working an entire shift in hot, cramped environments and needing to communicate with your coworkers. And it's a prickly issue, but one that the bottom line is that there are well-established controls that can manage the dust, and respirators should be seen as second, third, or fourth tier in that hierarchy.
There's some ecological factors. There are some changes in federal regulation which caused higher participation rates in radiographic surveillance. We don't know for sure, but we think that some of the enhanced standards related to the Part 90 transfer rights, where if you have evidence, radiographic evidence of pneumoconiosis, you can transfer to a less dusty environment. That was really codified right here during this period, and so we think that perhaps some of that resulted from that, but we're not exactly sure.
I think unfortunately it's hard to pick them up early. And I've seen a few cases where we've picked them up early, but when I say early, it's usually less than 15 or 10 years in the mining practice. And there's such a stigmata from the men's point of view that they don't want to know, and I guess that's some fear about health, but it's primarily worried about their compensation, whether it's federal or state. And Kentucky has laws that you have certain amount of times to file for your state workers' comp before you're not allowed to do it anymore. So we have a lot of men that are really hesitant about getting screened. But the variability, if you took 10 men and they were at a perfusion of a 1-1, which is kind of mild, and if you took those 10 out, we don't understand why some of them progress and why some of them don't progress. And after taking histories on these guys, one of the things that reoccurs, the vast majority of them, once they're taken out, will have significant declines within 3 to 5 years after they quit. So that's one of the things that we see is they actually breathe fairly well, even in advanced stages, especially the young ones, because of the capacity they have in the normal lung. So they don't get screened, and then they don't have the symptoms to get picked up early. So that's one of our problems with picking up especially our younger ones. But I don't know why they progress rapidly once they quit, but that's something that I see over and over and over is within a 3 to 5 year span, once they actually stop mining, that's usually when their severe symptoms will hit. So it's hard to pick them up that early, and usually if it is, it's because in some of these graphs you'll see a lot of this huge uptick that you see is because you had major layoffs in the industry. This was a part of this Obama's war on coal when we had so many layoffs. We got a true sampling population of miners. We had miners that had worked 30 or 40 years and had never been x-rayed because their breathing wasn't that bad and they were getting really high-paid jobs, but they were eventually laid off. And so we got a true sampling, I believe, of the population kind of in this time frame. So it's variable. There's no way for us to pick up, whether they'll progress or not progress, and it's really difficult to pick them up extremely early in the disease too.
And I'll add one thing. One thing that we see a lot of, especially in miners who do have early stage disease detected, oftentimes that's not associated with very severe physical symptoms yet. And so they want to continue working because the cold, hard economic reality, especially in a lot of Appalachian communities, is that with a high school education, coal mining is by far the best gig in town. You can make $70,000, $80,000 a year as a coal miner, as a continuous miner operator, or one of the better positions in the mines. And there are no other options that hold a candle to that in those communities.
So obviously that's a very political question. It's rooted in history. Back in the 1969 negotiations for when the legislation first arose to implement the dust regulations and the surveillance program, we had very strong union involvement. The unions were very much the case to advocate for voluntary participation and not force people to undergo medical testing that could be used to make determinations about their ability to work. And I think that there are a couple of issues. One is that if we were to create a system that required mandatory participation and removal from work, we would have to create an ancillary system to do something about that. Whether it's either through retraining, compensation. So it's really a social issue that hasn't been fully realized on both sides. And so we have the system that we do today because of those reasons. Sure. I mean, and as I mentioned, this is a highly political and contentious issue, and I think that primarily the safeguards that are involved with removing radiological workers from that environment have been put in place, where with coal mining that has not been the case, and it has not been something that has been seriously given consideration or addressed. And so those two things have to go hand in hand for that to work, and there has been politically a lot of resistance over time. But it's a conversation that I think we need to revisit. And
One of those miners in particular, Matthew Branham, when he was being interviewed by NPR, he reported that he had mined pure rock for months, right?
We actually cut the slope. When I say cut the slope, most of our mines in Appalachia, we simply bulldoze the face off and then they go straight in. You don't have to take a lot of rock. So slope mines, you'll actually have to mine down either with a miner, continuous miner, pure rock, or in his case, it was about 310 feet. So he actually did his mine pure rock for 7 months.
So that's pure sandstone, and that sandstone is 99% silica. Well, sure. I mean, so many of the slides that we have in here are peer-reviewed from peer-reviewed publications that are NIOSH publications and have been reviewed and approved by NIOSH and published in peer-reviewed journals. Brandon is not a NIOSH employee. A lot of what he reported from the third portion of the presentation is his personal experience, and he doesn't work for NIOSH or reflect NIOSH's views. And then the more simple answer is we put that on all of our presentations.
There are a couple of reasons, but again, this is a political issue. If you go and look at our peer-reviewed publications that have been cleared by our employers, you'll find that disclaimer on every single one of our scientific works, and it's the way that it is. they claim that it's in, I
The
don't,
claimants are just, he said, the claimants are just in it for the money. It's not much money. Like I said, you can make $80,000 a year as a coal miner. For a single beneficiary per month, the federal black lung benefits award you somewhere in the range of $800 to $900. Below poverty level money. They're not in it for the money. Said,
Can you repeat that?
do you have a comment?
I think he would be the best.
What was the question?
Can you repeat the
Can you repeat it? Well, I don't have the same constraints, these guys do, but I mean, there's no doubt it's a big business because you have so many men involved in it, and where there's money potentially, then you're going to have people involved in it. I was a fourth-generation miner. My dad's a miner. He's got black lung. My grandfather, his father. We were operators. I went to work when I was 14 because I was doing stuff I shouldn't be doing, so they put me to work. But it's a major problem, but the way I look at it, it's an opportunity for major solutions in the coal industry. We're doing education, but we need cooperation with the companies to go out on those directions that we think's causing, or I think's causing it, that I've picked up in these cases. And there's potential significant benefits, economically if you understand this disease and you can curb the disease just from a financial standpoint of the company and health savings, but also if they have a safety division which helps curb it for the rest of the country and the worldwide. So there's no doubt it's a big business, but you have to kind of look at it from a patient point of view too, which was what was most concerning for me.
So I think the easiest answer is that what David said, which is you're not going to get this without the appropriate exposure. You have to be exposed to a sufficient amount of coal mine dust. The exposures that we showed you today of these radiographs, there's no minor genetic predisposition or markers that are going to be able to account for this level of impairment. There is some work that's going on in the field to look at predisposition factors. I don't think it's particularly promising.
Thank you. All right. Well, I'd like to thank you all for being here. We have some parting gifts for you, of course. You can see the big boxes there. But we also have the privilege of bestowing on each of you the title of Honorary Professor in the College of Public Health. Thank you all. It was really, really great. Two final announcements. If there is someone here who's missing a phone and an ID card, whose name is Heidi, please come forward. And for a small fee, we'll be able to give that to you. And then finally, the next Leading Voices is the Justice, Health, and Humanities lecture, which we co-sponsor with the Department of Philosophy. It'll be on October 10th. Thomas Shapiro, the author of the new book, Toxic Inequality, will be giving a talk called Toxic Economic Inequality Meets Racial Injustice. Should be an interesting topic. Look forward to seeing you all then. Thanks again for our speakers this evening.